Welcome to Kids Matter. I'm Dr. Elisa Minkin. As a pediatrician, mom, and grandma, I understand how challenging it can be to help our kids grow into their best selves. We are so much more powerful together. Here, I will be sharing the knowledge and wisdom of a wide range of people who understand and care deeply about children. I'm hoping for your input as well because kids really do matter. They are our future. Welcome back to the Kids Matter podcast. I am really honored and really excited to be interviewing Dr. Wendy Ross today. Dr. Ross is a clinical professor, developmental pediatrician, and the inaugural director of the Jefferson Health's Center for Autism and Neurodiversity, JeffCAN. She graduated from Mount Sinai School of Medicine and completed pediatric residency at Yale and Developmental and Behavioral Pediatrics Fellowship at Harvard. In her clinical practice, she works with children to clarify and support their development, integrating medical, educational, and therapeutic plans into a cohesive approach. In her broader program, her work focuses on improving community belonging by advancing neurodivergent-friendly healthcare, design, and everyday experiences. Most recently, she consulted on the show The Pit, advising them on the development of autistic characters and stories, specifically Mel, my favorite character. So thank you so much for joining me today, Dr. Ross. To me, you are my inclusion hero, and I'm really passionate about that as an autism mom and pediatrician. So thank you for everything you do.
Well, thank you so much for having me. I'm excited to be here.
This is amazing. So I want to start with how did you get started in this area of inclusion?
Well, so I was doing general pediatrics and developmental and behavioral pediatrics. So I had originally like a nice balance of things that, you know what, you're a pediatrician, right? Like an ear infection, a sore throat, those things are kind of quicker fixes, right? And then that kind of counterbalance some of the more chronic, ongoing developmental challenges that some of my patients had. When I moved to Philadelphia, I was just doing developmental peds. And what I began to see was that my patients and their families were not going out in the community because they had a child that looked typical but didn't behave typically. And when that happens, people look at you like you're a bad parent, right? So, and then their neurotypical peers and siblings weren't going out. And, you know, the worlds were just getting smaller and smaller. So I decided to start to work on that. And I started with museums because that's where kids go to socialize and play. And my patients could neither socialize nor play typically, right? So, and then once I got started and people began to do things that they didn't think they'd be able to do, I'm just going to be honest, I got like a little hooked on that. So, so.
Well, we're all grateful that you did, and we're going to get into more what it means to make places more inclusive. But I first want to talk about what it means to be neurodivergent. And I want to define neurodivergent versus neurodiversity, please, because that's a personal pet peeve of mine when they're interchanged.
Yeah, well, I think neurodiversity is kind of like the noun, right? And neurodivergent is kind of the adjective for an individual, right? So, um, and what happened in the history of sort of autism and the nomenclature is that first there was sort of classic autism, and then there was this umbrella of PDD or perversive developmental disorder, and then there was like Asperger's over here, which were like the little professors, right? And then the diagnostic and statistical manual took those away, and they made the whole umbrella just autism with different levels, level 1, 2, and 3, from people who need less to more support. And when that happened, the word neurodiversity and also neurodivergent had been around. It's been around for a long time. It was created by Judith Singer, a sociologist from Australia, who herself, I think, is on the spectrum. And it was reflect the fact that somebody could be neurologically different or divergent or, you know, reflect the whole diversity of minds, right? But not be less. It was more of like a neuro-affirming perspective. And I think for a large number of people on the autism spectrum that can fit them, right? Maybe not somebody with a more profound kind of autism, but a large number of them. And the truth is we do need all kinds of minds. But this word started to get more and more used once we removed Asperger's, because, you know, it sort of took on that reflection of sort of what used to be that Asperger's profile. So people use neurodivergent, and because neurodivergent literally just means different neurologically, it came to also encompass other people whose minds think differently, who process language differently, interact with their environment differently. So this could include somebody with ADHD or traumatic brain injury or somebody who's just aging. And so that sort of became more widely used. And it is interesting because even the people who previously maybe would have been identified as having Asperger's began to really take to the word autistic, and in fact really seem to prefer. This was also a shift from being called a person with autism to an autistic person. Now not everybody prefers that, but a lot of self advocates are quite vocal on that point. So I think a lot of things have been changing in the no, and what these words mean and how they're perceived.
A great explanation, a great little summary of the history. I want to talk a little bit about you talked a little bit about person first versus diagnosis first, and I think that reflects the ideology of identity
Mhm.
versus disability. And so I want you to talk a little bit about that. I know it's controversial. We're not going to talk about anything controversial here today. This is not a controversial
Yeah, yeah.
interview.
Well,
So I want to
I
stay just very
think,
basic about this. You know what I mean? Like, why would someone prefer to be called autistic and why would they not?
well, I think, and again, we'd have to really ask a self advocate this, but I think, they don't see their autism as a disability. It's just a difference for them. And it's an integral part of who they are and how they interact with the world. And so they think it's not something that is with them, it is something that's a part of them. So they prefer identity first language. And I think it also reflects on sort of a social construct of how we see people. So sometimes when you think, it's this idea that people may not actually have a disability per se, but what they have, if you look at it in a different way or reframe it, is sort of a difference between the world around them, like a mismatch, and themselves, right? So, for example, if everything were situated lower, then it would be people not in wheelchairs that would be at a disadvantage, right? So it's this idea that there's a mismatch, not that there's a lesser. So I think a lot of those things are intertwined.
That's a really good explanation, and it'll bring us to what you do for inclusion down the road for different environments. We're going to talk about that. But I want to speak to clinicians right now because this shift requires you to change your lens, right? You, if you look at everything as a disability, right, that can be problematic for seeing the whole child,
Yeah,
right?
yeah, I agree. I mean, I think to some extent we always want to presume competence, and look, I'm humble enough to know that even my perception has changed. So I've been doing this now for 25 years, and kids that were non-speaking, that we kind of assumed that that meant that they didn't understand. Now that they have found a way to communicate, we find that they did understand quite a bit, right? So I think, I'm also learning in this process and as things are evolving. And I'm very hesitant, for example, to your point, to even provide sort of this level system in my practice because I've had patients now that I'm old who were maybe non-speaking until the age of 4, but now are in medical school. So if somebody had sort of said from the beginning, your child is high need or low functioning, like would that child have been afforded the same opportunities and exposures to get them where they are today? So look, I'm not at all denying that there are people who have really significant amounts of autism and it is a true disability, so I also don't want to discount that. But I do also think that there's other people on this big spectrum that, like, for them, that is more of a neurodivergent situation.
Absolutely. And I want to clarify, we're talking about level 1, level 2, level 3 autism, which is a newer kind of construct.
Hmm.
And it's supposed to be about support needs, but it often
Yes.
gets reframed as how autistic are you? That's a problem.
It is a problem because even people who, and I don't love these terms, but, people will say high functioning, low functioning, but even people who are considered sort of, in quotations, high functioning, can really have significant challenges. Like we did a study
Right.
with Autistic Doctors International, which is an amazing group started by Mary Doherty. And, a lot of the physicians in that study sadly had dropped out of medical school or had suicidal ideation or suicidal attempts. And so I wouldn't say that that's low need, actually, just because somebody has cognitive strengths and was able to access their academic curriculum. I don't know. I mean, I think it's a different way of having needs, but I wouldn't say it's less.
Right. It's really important that you said that. I really want to underscore that because part of the way we look at it is we look at what do I see,
Mhm.
right? I see someone who doesn't speak, or I see someone who's flapping, or I don't see anything wrong with that person because it
Mhm.
can be such an indivisible disability.
Mhm.
It's so individual. My favorite line is the most quoted line, with Stephen Shore's line is, if you've seen one person on the spectrum,
Yeah.
you've met one person on the spectrum. I'm messing it up, but that's the
Yeah, if you
basic
know
idea.
one person, that you know one person, that is true. Because while when we think of autism, we think of differences or challenges in communication, in social skills, and in behaviors. And usually sometimes when we think of the behaviors or the special interests, but we also think of like a sensory component, right? Sensory seeking or sensory avoidant. But how that can be presented in an individual can really vary between people and even within one person, right? Like I could be sensory seeking in one way and sensory avoidant in another way. So it's really variable.
But not just that, but you on one day can do something and the next day not.
Right. And I think that has a lot
Right.
to do with, this idea of getting burned out, but it can
Right.
also have to do with sort of executive functioning. And I think executive functioning is something that's more and more we're talking about as a part of ADHD, but also a part of autism. And it's about how we organize and retrieve skills that we need to execute a task, right? So when I'm explaining this to parents, because, when a child can do something one day and not the next day, the assumption is that they're not trying, right? But sometimes it's sort of like they have that skill, but they don't know where they put it. So I'll describe that like, you have your silverware drawer with those little, there's like a little section for your knife, your fork, your spoon, and you don't even, you've muscle memory for it, right? But then imagine if all your silverware were just thrown in there. So it's there, but you can't, get it efficiently, and utilize it. So executive functioning is really important, and it is generally a part of the autistic profile.
I love that because you just took the spoons methodology and added another level. I have the spoons, I just can't find them.
Mhm, mhm.
Right. The idea of spoons is, do you have enough spoons? Do you have enough bandwidth?
Yeah,
Which is very commonly used with people on the autism spectrum who have run out of spoons, right?
right.
Who don't have the bandwidth to do whatever. So it's interesting because I want to talk about the inclusion projects you've done, but I just want to have the idea out there that inclusion just doesn't just mean physical inclusion, right?
Right. I think this is really important. I think the Americans with Disabilities Act, of course, covers the neurodivergent population or people, but there are no guidelines. So it's much harder to enforce it. And sometimes what happens is people will stick in a sensory room and check a box. And it's not that sensory rooms are bad, but what's bad is that they're the only option because they're segregated, they're not truly integrated. So it's good to have an option like that, but it can be a little bit performative at the end of the day. Like, surely we can have better options along with that, right? So, and it's also interesting because the terminology for this has also been changing. We used to talk about accessibility, right? And then we sort of talked about inclusion. But I was talking to Jennifer Cook, who's like an amazing self-advocate and author, and now she's on Love on the Spectrum, and she's just amazing. And she and I were talking, and she was saying, inclusion is actually kind of patronizing, right? It's kind of like I have something, and maybe I'll let you in. So she and I were talking about this, and we really prefer sort of the term or the word belonging, right? Because it's sort of like we all have a spot. It's not like
Love
I'm
it.
making a spot for you, like your spot is here,
Right.
you know?
Right. And that's going to take time,
Mhm.
right? So I want to hear some of the things you've done to make places more inclusive or help people belong, to use your
Yeah.
terminology.
Well, I just want to start like there's sort of a cultural shift, right? Like there's this
Hmm.
idea that if you have a disability or a challenge that manifests as a behavior or something like that, that somehow the onus or burden is on you. Like you would never say that about somebody in a wheelchair. Like if there was no curb cutout or ramp, it would be obvious to you that there was something wrong with the setting, right? But for people with intellectual disabilities or autism, somehow that hasn't been the way of thinking. And so, we have been seeing that shift quite a bit. I mean, I've been doing these types of projects for almost 20 years. And, we talk about this like a ramp, but it's a ramp of sort of social understanding, skills, sensitivity, patience. It's more all these other things that really make up empathy, actually. And just like a regular ramp was created for wheelchairs, but benefits people with walkers or strollers or delivering things, then, this type of ramp really does benefit a lot of other people, right? And at the hospital, when we talk about neurodivergent affirming or friendly healthcare or whatever you want to call it, it's the kind of care that some people really have to have, but that everybody kind of benefits from and deserves. And so it's just better care to some extent because it requires you to sort of take an extra few minutes to be more curious than judgmental and to take in a little bit more of what your eyes as well as your ears are saying and to incorporate caregivers in a considerate but mindful way, because a lot of times caregivers do know their people. I mean, you don't want to exclude the individual, but neither do you want to totally block out a caregiver, especially if, when the gestalt is that they should be included, right? So I think there's a lot of nuances to this. So I think, but just going back, I'm sorry I got off on a tangent, but
It's fine. This is great stuff.
so
I love it.
started to work with museums, and initially it was a little bit of a tough sell. I tried to convince them, play is considered a human right by the United Nations, and I said they were denying my patients their human rights because they couldn't play safely or in an understood way at the museums, and that did actually not work. But the museum conferences were coming to my town, and I submitted panels, and so it was an easy way for people to be included on a panel. So then one by one, they started to participate. And it involved, we have kind of like a model. So we prepare the families or individuals, and then we prepare the site. And we also provide resources. So for the families and individuals, we would provide like social stories by Carol Gray. We would create visual schedules and sort of like a plan, way of planning so people knew what to expect. And we would provide some crossover hours. So it wasn't just a totally separate day, but it was like an early opening, a soft opening that transitioned into the regular hours. And then we would also, educate the people working at the museum and provide them with just some foundational knowledge. I mean, we didn't expect them to be autism experts. We just wanted them to have a sense of understanding and some skills and strategies and tools in their tool belt. And, we made some sensory accommodations on the sites. And, for some people, the kids, initially it was just kids and then it became more adults as well. But some kids, like at the Natural Science Museum, they knew everything there was to know about dinosaurs, okay? But they couldn't tell a narrative or have a reciprocal back and forth conversation. So for them, we started a docent program because when you're a docent, you have to sort of be able to tell a narrative and have a reciprocal conversation. So we leverage their special interest as a motivator, right? To like,
Love it.
so that was one thing. And then for people who are on the other end, we did other things. So like we would make bags of manipulatives and have them match the manipulative. So at whatever level you were, there was some way for you to access the museum, whether it was by just getting you in the door and to experience something related to its content, or it was leveraging your special interest to help you build a life skill. So that's sort of where we started. And then when we were at the national conferences, the Smithsonian invited us, and we were like a little team. It was myself, a psychologist, an occupational therapist, and a speech and language pathologist. We're a little interprofessional group. And then I had a patient that got stuck on a flight, and we had prepared this family for their trip to Disney. But what I didn't anticipate was that the airline was Southwest, where you're not necessarily assigned a seat. So on the way home, it became impossible for the whole family to pre-board together because people thought they were taking advantage, And when the mother and this one child pre-boarded, she got very aggressive because she didn't understand, right? Like where the rest of her family was. And long story short, this plane took off without this family of five. The plane had all their car seats, everything on it. And so I was very upset. I don't usually get very upset by so the airport wanted me to sedate this child, and I was like, "We're not. I don't even sedate kids on the ground, so I'm not going to sedate them
Sure.
in the air." So I said, "You know, I think we just need to let them pre-board as a family, right, and see what happens." And so we did get them home. But even before that, I also called Philadelphia International Airport. I was really upset, and I spoke to the ADA coordinator there, who was an amazing guy. And I said, "Listen, did not happen in Philadelphia. So I'm not." I said, "But we really, like, we need to do better. Like, I'd really love to come in and educate TSA, airports, and airlines and prepare families and have mock flights." So we had the first kind of mock flight experience anywhere at PHL, and that was really cool, and then people started to be able to fly. So for some families, they just needed to be familiar with the process, but for other families, well, we provided support for all the families, but some families really required sort of that level, like some support to help them problem solve or troubleshoot on site. So every family had somebody. And then Senator Lautenberg from New Jersey had us come to Newark, and we started to work with the Department of Transportation. And we created the TSA Cares hotline, was inspired by this work, that where anyone can call that hotline and get help traversing TSA. So yeah, that was really fun. And because travel is so much more from how you get from one place to another, it's really about opportunity. And that's the Secretary of Transportation at the time, Ray LaHood, said that. Is such a great quote. And then I really wanted to get in with the sports teams, because anyone who's been to Philly knows that our sports teams are like a very big deal. Not that they're not a big deal everywhere else, but Philly fans are special, right? They have their own. So I got in with the Phillies first, and we started a game day experience. We trained all the staff at the park. We prepared families, and we brought families to games. And then it was the Eagles, and then it was the Flyers, and the Sixers are in the same building. So we were able to do a lot of that work. And so it's just this model of preparing the family or individual, preparing the site, and then hosting a supported experience that hopefully would lead to a follow-up, more independent experience. And that's sort of what we do.
Love all that. And when you say a supported experience, do you mean like autism game night? Is
Yeah,
that what
well,
you're
we
talking
didn't
about?
just do a game night. We would get tickets to multiple games throughout the season, and we would bring families. So each family would be assigned like an OT student or a speech and language therapy student or an actual therapist, and we would all go to the game. It wasn't just on a special night, because, in real life, we don't just go on one night. We go whenever
Right,
we want, right? So we
right,
wanted to really try to do other nights.
right. That's what I'm trying to bring out. As you mentioned before, the segregation approach. To me, however well-meaning it is, the sensory room or the game night for autism, where it's autism friendly, is a segregation approach, right?
Yeah, I mean, I
I'm
don't
not saying
think
it's all bad. I'm just
Yeah, I don't
saying.
think there's anything wrong with that. I think the
Right.
problem is that people stop there. And
Exactly.
right now, like, one of the reasons I really wanted to be at Jefferson Health and Jefferson University is that, like, I am officially stationed on the health side because I'm a clinician. However, there's a university not just for healthcare, but for design. So we have fashion, interior design, architecture, industrial design, immersive light-based art. And in those courses, what we do is we integrate health design and, most importantly, the community. And we ask the community first what they want. We don't try to just guess and do something and then get them to say nice things, kind of shoehorn it, right? Like, we're really concerned about incorporating perspective. And we designed a line of furniture for our medical building with Miller Knoll. And one of the things that we did with each iteration of that seating was we brought in individuals with IDD and or autism, but we included non-speakers, and we would videotape them and code their behaviors, and like low speech people, like people who would just echo, because they would say, we'd ask them if they're comfortable, and they would say yes, but they would look obviously uncomfortable. So we were like, okay, we need to do better, to get their perspectives. But Jefferson is a really remarkable place because I heard a few years ago that they were putting up a specialty pavilion, so a building for, cardiology, pulmonology, oncology, so that if you had multiple conditions, you didn't have to go to this office on, 11th and Chestnut and that office on 10th and Market. Like, it was all in one building. So I heard about this and I went to my boss at Perbican, who's like amazing. And I had a whole slide deck ready. I had a whole like pitch. And I'm like, my population is never considered from the beginning. Like they're kind of like an afterthought in these designs. And could we possibly like do focus groups and interviews and try to get some perspective from them, before this building is designed? And
Literally
before,
get in on the ground floor, right?
yeah, literally on the sub in the sub basement,
The
and
subbies.
yeah, and the foundation. And before I could even take another breath, he was like, "Yes, like let's do it." And I didn't even have to show him all those slides. And that's one of the really special things. I don't mean to sound like a commercial. I mean this like sincerely about Jefferson. I mean, no place is 100% perfect, but the things that drew me to Jefferson were the mission and vision to improve lives, do the right thing, be inclusive, and be innovative. And the other was the School of Design, because I had been working on processes, but the built environment, because of the sensory issues, can be hugely impactful. So I'm not a designer, so I knew I needed designers. So I really badly wanted to be at Jefferson so I could have access to, they have an amazing center for architecture and the built environment, but now it's going to be expanded to industrial design is going into there. But we also have an adaptive fashion class, which is outside of that umbrella, and it's really been just a lot of fun.
That's incredible. Can you give us an example? Because people may be thinking, what adaptations? What are we doing differently?
So it depends on what you would ask about. So in that building, we designed a line of furniture that has some, like, I don't, wall sounds bad, but like some, coverage, right? So that you're not totally exposed, which frankly, a lot of patients prefer. You already feel very vulnerable when you're a patient, right? So sometimes you want to be a little encapsulated. And we created semi-enclosed alcoves that made of a natural kind of wood material. They have a really good texture. They let us pick a lot of textures in this building. They let us pick some lighting. We got to help with the exam rooms are really cool. The chairs check your weight, which takes away an entire transition if you think about it. And the weight gets imported directly into the electronic medical record. So nobody, I mean, I don't know personally anyone who wants their weight shouted out. Like, okay. And then when you check out, a live person will come on the screen in the room so that you don't have to, let's say, go to the waiting room and stand on another line in a crowd of people to get your follow-up appointment. So there's so many things. I mean, I can't even list them all right now. I would take up the whole day, but we have bathrooms with adult changing tables. I mean, there's just a lot. We have a piece of amazing artwork by Campbell Smith, who's an autistic young man. He's an award-winning artist, and it's a model of the building, which we commissioned to also point out that there's a strength-based perspective here, not just a needs-based. So there's ambassadors in that building that help everyone. If you're lost or need assistance of any kind, there's sensory bags that you can access. Um, we really try to think of a lot of things, and we really try to do a lot of training, because at the end of the day, especially in medicine, like sometimes we get bad news, right? And there's nothing we can do to change that, but just being kind and patient can make a huge difference. So that's sort of one category, but we had an adaptive fashion class. I'm trying to change the name because it's not sexy, that name, but I'm campaigning. But anyway, it's a required course now. We usually have about 60 students a year in it, three classes of 20, and we have clients who either have some, autism, or some might be in a physical disability as well, or so, and the students are learning to design for them, and the clothes for the autistic individuals might be really sensory friendly but really stylish, not basic, right? So um we had one little guy who really wanted to wear leggings, but like his mom didn't want him just to wear leggings, because like little boys sometimes don't wear leggings, I mean they can, right? But so there's sort of leggings on the inside and cargo pants on the outside. So, we made a lot of different fashion. We have immersive light-based art, and that was a course with Lynn Godley, who's amazing. And this is artwork that is animated with light, and it's super calming, and it instills a sense of awe. We're starting to look into its impact. And to their credit, the hospital bought 11 pieces of this art and put it into that new building. So there's all different things. We take clients. We also consult. So if anybody wants a neurodivergent consult on their building, we can take a client on for a course. So we have courses. We created a neurodivergent-friendly residence hall at St. Joe's University. So that was one of our clients. So there's a lot of things. And we do get hired. So like the Pennsylvania Supreme Court, Justice Dougherty had us come to try to make the family courts more autism friendly. So we did some things with design and with just education across the state for that project. So there's a whole
It's really
range.
important because it's not uncommon because parents often have to get guardianship or similar things for their autistic kids, and they're often asked to bring them there. So that's really important.
Yeah,
I mean, it's all important. And
yeah.
you've been saying so many good things. I have
Oh,
a couple of
sorry.
things I
I'm
want to put
sorry.
in. No,
Yeah.
you're great. I'm just listening. Oh, the hair is bleeding. One thing is you brought up over and over subtly the idea of universal design. So people think, oh, we're doing this for a very specialized group and we're spending all this resources and money. No, it's better for everybody. A lot, not all, maybe not everybody needs an adult-sized changing table, but a lot of the things you mentioned how it can be helpful for a lot of people. Number two, if you're not talking about just the tip of the spectrum, the most obvious, and you understand that neurodivergence is actually common, right?
Mm-hmm.
Is it like what percent of the population would qualify? Is there a number?
So many. I don't, it's hard to tell. I mean, and some people really don't know that they're neurodivergent,
Right.
right? Like, so it's hard to say.
Right, but we all have all kinds of needs. We have neurodiversity, which means our brains are all different. We all have strengths and weaknesses, and it's accommodating a lot more people. That's the concept of universal design. Like you said, like a curb cut could be not just for a person with a wheelchair, but for a person with a stroller. So we do it for everybody, right? Would you say that's a fair
Yeah,
use of the term universal?
I think so. Yeah.
Okay. And one other thing, I want to go back because I feel like I didn't misspeak, but I wasn't nuanced enough. When you have something like Autism Night and everybody there are families with kids with autism, that can be phenomenal. It's not just it's okay or it's not good enough or it's not enough. Different people and different families need different things, right? And it's all about, like you said, belonging. There's different ways to belong. And you might want to belong to your sub community, right? You might want to go on Autism Night so you can be with all the other families where you don't have to, or also your kid can behave a certain way and it's okay because it's not always okay, right? You may be able to coach some kids and families into attending a regular game, but they might not be able to with all the accommodations, right? Would that make sense to you?
Yeah, that does make sense.
So different options, I think, are all important. So I didn't want to make it sound like segregated programs are lesser or not good. They just shouldn't be the only thing out there.
Yes, absolutely. Yeah.
Yeah. So I want to actually pivot to what things can regular people do to be more inclusive, and also places that don't have the ability to do the kind of design you're talking about, or people who don't have access to those kind of places.
I'm sorry. Can you rephrase that?
Sure. So when I hear these things, I think of, oh, this is so ideal and this is so beautiful. And not everybody has access to those places, right? What if you are living in a community and you just want to be, as a regular person, you want to be more inclusive and you don't know how? Or what if, say, you work in a pediatric practice and you can't get it redesigned, but you want to be more inclusive and more have people belong?
Yeah, I think at the end of the day, we try to work on the design, but I think some of the most important thing is that, look, the most important asset for belonging or inclusion is our empathy, right? And I think that like just being really patient and kind, like there's no design substitute for that actually. So
Right. You may not be able to accommodate, say, the way your waiting room is, but you might be able to accommodate, say, the time of the appointment. So I brought somebody into my pediatric practice who is an expert in autism and advocacy and worked with the entire staff to be more sensitive, more empathic, and more understanding. And we would do things like, okay, this is a kid on the spectrum. We're going to have first appointment or last appointment, or we're going to meet them at the base of the stairs because he couldn't come upstairs and we're going to get what we can done there. Right?
Yeah.
Or we're gonna do the visit in the waiting, whatever. We've done different things. We've modified it in different ways in order to accommodate, be as accessible as possible.
Yeah, and sometimes it's a matter of desensitizing somebody, right?
Right.
So, like, you bring them in first just to see the space. You bring them in the second time and you just put the cuff on their arm. You bring them in the third time, then you squeeze the cuff. Sometimes it just takes a long time and um work on this. And I think that, being ourselves flexible is, to your point, really important. And also sometimes to just be attuned or to join somebody. So sometimes if a child is doing something, to sort of just, if they're under the table, to your point, exactly, go under the table and sit with them for a minute. Like, don't just, and to really ask the parent, like, what works best for your child? Is it better if I say what I'm going to do? Or is it better if I just try to do it real fast? Or is it better, because parents are experts on their person, you know,
What would you say to, say, a clinician who says, I really want to do this, but I'm just not so knowledgeable or comfortable?
Well, I think, there's all kinds of ways to get comfortable, right? Like, if you have already families in your practice, you could talk to them, or you could go to a nearby university where there's developmental peds and see if there are lectures or grand rounds that are happening, or, reach out to the Autism Society of America or Special Olympics. Like, there's all kinds of ways. I think part of the issue is that people sometimes don't know what to do, but I think also they don't always have a lot of time for patients. But if you code on the billing sheet, not just like if a patient comes in for an ear infection, but like an ear infection and autism, then you can bill at a higher decision making and more time. So then hopefully you're getting compensated for some of that extra time that you're investing.
And you can also make a separate appointment. I'm a huge fan of making separate telehealth appointments without the child. You can focus better, you can take more time, and it's a different visit because there's only so much, no matter how you code, that can be done in a unit of time. Right?
Absolutely.
Time is not
Yeah.
elastic. All the other patients are sitting there in the waiting room waiting, and
Mhm.
we have to acknowledge the time burden that clinicians have nowadays.
Yeah. Yeah.
Right?
And to your point, getting the parental history on Zoom beforehand and then just having the visit focus on the aspects of the physical that you need to do. I just always worry about diagnostic overshadowing too. So, not that you would ever do that, but we see that so much where our kids don't actually get examined sometimes. Like, especially in like an urgent care, an emergency situation, like a behavior will escalate, like head banging will increase. And, the clinician might say, well, they're autistic, they bang their heads, but it turns out they have an ear infection, right? And I'm sure you would never do that. I'm just saying that, like, we have to be really careful to do the exams maybe in different ways, but not to not do them.
You can't skip the exam, and you also have to keep asking. The parents tend to know their kids best. What do you think? What do you feel? What's your experience? What has changed? Right? And
Mhm.
understand that autistic behavior is a form of communication,
Yeah.
right? What is the child communicating? Not just, hey, I'm autistic, but
Yeah.
something hurts me, for example.
Right. What
Right. That,
function does that behavior
yes,
serve? Right. Yeah,
right.
absolutely. And I do think it's really, really important because to exactly what you said, parents do know their kids. There was a study that showed that mothers of kids with autism, I mean, it could be dads too, but the study was literally moms. So I'm just going to say what the study was, have as much stress as them as soldiers stationed in combat zones. And it wasn't just by asking them, it was by looking at the cortisol levels. So I think sometimes
Oh,
parents
gosh,
kind of
yes.
come in hot because they're used to arguing with schools. They're used to, negotiating for IEPs. Like, they're constantly vigilant about, protecting their child. And then, sometimes people don't listen to, they are experts in their person, right? So
Yes. Louder for the people in the back. The autism moms and dads are experts on their kids.
yeah.
Ask them. It's very frustrating as an autism mom, to have felt sometimes someone talking down to me, like, you're not asking me, you're telling me, and I know what you're telling me already, and I know a lot more.
Yes.
Not just because I'm a physician, but because of my being an autism mom.
Yeah, I think it's really important because people know when you're patronizing them or not listening to them, or you're looking at them like they're a crazy anxious parent, when in fact they do have really important information to portray, because you might be an expert in the medicine, but they're an expert in their person. And so it's really important to collaborate with people. And if people do come in a little bit hot, to respond and not react, right? To sort of understand, like, where, how you can best, again, meet with them, join with them.
Right. And it might take another visit, and it might take you walking out of the room and catching your own breath for a
Hmm.
minute. That's
Hmm.
okay.
Yeah.
And also back to the patient, the child, the autistic child or young adult or adult, not to forget them, even if they are non-speaking. I love this new word, non-speaking, as opposed to nonverbal. The idea being that just because I'm not saying anything doesn't mean I have nothing to say, nothing to communicate, right? And that they may be understanding every word, but even if they don't understand every word, they're a human being, they're in front of you, and involve them as best you can as another human, right? It sounds so obvious, but sometimes people don't know how. And I think my answer to the question I asked you before is just keep doing it, because the more you do it, you'll get more comfortable and you'll learn more as you go, and just keep asking, right? Ask the autistic person, ask the parent, ask everybody you can possibly ask,
Yeah, I
and
mean,
keep learning.
yeah, to approach with humility. Like I know, like
Right.
I fully acknowledge mistakes I've made. Like when I look back over my developmental pediatric life, like I realized, for example, like there are some girls that I've missed, and that now I would better understand as being on the spectrum, but it just presented differently.
But we're learning more as we go along. And I love Maya Angelou's line of do the best you can until you know better. When you know better, do better.
Mhm.
Right? We're learning more about the wide spectrum of autism, and all those male people who told us what autism is
Mhm.
have colored it one way. That's a whole separate podcast. I want to go down a different day. But you can't blame yourself. You remain humble and you keep learning, and you keep, starting each new day with that new knowledge, right?
Mhm.
That's all we can do.
Yes. Yeah.
Right? So speaking of females on the spectrum, can we talk about the pit, please?
Yeah. Yeah, so that was really a big surprise to me. So there's a group at the University of Southern California that attaches like subject matter people to entertainment people. And they reached out and said there's this show in an emergency room with a doctor that's autistic, and we don't want like a savant kind of doctor, and could you speak to them? And that was all the information really I had. I don't think the show had a name or was even 100% picked up, or was a couple years ago. And I logged in and there was, writer's room, and then there was Noah Wiley. So that was really shocking. Yeah, and we talked about this character, and they used everything I suggested, and most importantly, I also told them to reach out to Jennifer Cook, who's a self-advocate, and they also did that, and she's consulting a lot on the second season on, and, especially like Mel's sister as well as Mel, as things got more complicated. But I said it would be interesting to have a woman doctor who's not sure, who you don't know if she doesn't know that she's on the spectrum or she's not disclosing, and who it kind of dawns on you gradually over episodes, like a little bit of this, a little bit of that. Like you see that she stims one day, or she's really drawn to like a methodical task, like a debridement another day. And then another day, she kind of doesn't read the room and says something that maybe somebody wouldn't have worded in the, to a parent the way she did. And then, most importantly, and this happened to a medical student or a student, and now he's a medical student that worked with me. He told me his name is Fox Riker. He's amazing. He used to work in an emergency room before he was a medical student. And he said, when I'm in the emergency room and somebody autistic comes in dysregulated, I know it intuitively, like I know exactly what to do. So they like call for, because and you kind of see that happen in the show in like episode 6 or 7. I think she's such an interesting character, and they did such a great job. And I think one of the things that's so special about that show as a whole is that there's an allowance for people to be vulnerable, but that doesn't necessarily equate to weak, and in some ways they make vulnerability kind of a strength. It's interesting how they tackle so many issues in one show in 15 hours a season, but like it is really it's a special show, I think.
They're very intentional, and
Hmm.
and you've been very intentional about Mel. And it's interesting to hear that they asked you for an autistic character, and yet she is not diagnosed as autistic. And if you look at the media, the people in the autism world, it's like, if you know, you know. And then outside of it, people are like, hey, there's the neurodivergent character, and her sister's autistic. And I think it'll be really interesting over time, the way I see it. And I don't want to be any spoilers for people who haven't seen it, but she's getting stressed on the show, right? And so I don't know if you want to talk a little bit about what it would be for someone who might not be diagnosed, specifically female, like a character like Mel, would her ability to function, like we might call it masking or camouflaging, remain stable, or would that change? This is a very specific question.
No, that's okay. I think this is an important topic, this idea of masking and how it adds such a level of cognitive burden to the individual. And I think Mel is interesting because she does mask, but she also doesn't mask at times. And what's special is that people don't like, sometimes she's a little odd and people don't treat her like she's a little odd, at least for the first season. You know what I mean? So I think um, that's also kind of interesting is that she's kind of accepted. And at one point, Dr. Robbie kind of says, you're a great doctor. He says that to her. So I think that that's really nice to see.
But also, representation is everything, right? So if we're talking about making a cultural shift,
Mhm.
right, then we need to move beyond the tropes of, say, Rain Man or the
Mhm.
good
Yeah.
doctor, right? The savant. She's not a savant.
Mhm.
And back to her not being diagnosed. I still want to go back to her not being diagnosed because I think that's a very common scenario. She rings very true as
Yeah.
someone who is different. She knows she's different, but either she has a diagnosis and she's not telling everyone. We don't know that.
Right. Well,
Or
I
more
also,
likely she's missed, honestly.
yeah, well, I think the thing is also her sister is identified, and I think this happens in a lot of families that one person has a more significant form of autism, so the other person doesn't present like that, so they're like, "Oh no." You know what I mean?
All the
Even
time.
though, so I think that's part of it, but I don't think she ever needs a diagnosis because when you look at sort of the literature by Autistic Doctors International, a lot of people are not officially diagnosed, and I think, even with a diagnosis, if you know one person, you know one person, right? So
Right.
it's really about how do we meet people's needs and just be understanding and empathetic and recognize their strengths and that their strengths are worth accepting some differences, or even encouraging some differences because that might make them sort of think differently. The world has so many um there's so many complicated things, problems to solve, right? It's going to take all kinds of minds. Like, even if you just look at how quickly AI is coming, like, there's just a lot of things happening in technology and in science and in other aspects of our world that really do require people to think differently. If we all thought the same, we wouldn't have a lot of advances.
Right. And I'm going to bring this up. I don't see a stark line in the sand between autistic and not autistic. I see it as a spectrum that blends seamlessly. And there was a book years ago by, I think his name was John Rady, called Shadow Syndromes.
Hmm.
And if you're familiar with that,
I'm not.
the term broader autistic phenotype, that was used way back
Yeah, I've
also.
heard that. Definitely. Yes. Yes.
So I think that there's a zone, right? And I think a lot of people who are self-identifying might be in that zone, and I'm fine with that. But there are other people who are in that zone who don't want to identify, right? And I think that if they are in that gray zone, I think it could go either way. And I think that's where some people want the identity and some people don't. I don't know what you think about that.
Yeah, no, I agree. I mean, I think it's possible to have some autistic features and still not be autistic. I think, Jennifer Cook talks a lot about the human spectrum.
Hmm.
I don't know that all self advocates would agree. I think some people do think there's a more stark line in the sand, but I think we do see a lot of the blurring around the edges now. And again, I think it's not necessarily about a label, but it's about understanding yourself and how to optimize accessing the things you want in the world, getting skills where you may not have them intuitively to help support things that come easily to you, right? When kids go to school, it's common parlance to talk about straight A's as being this goal, right? But in real life, we don't get straight A's. Like, I don't know anybody who's good at everything, right? We either do what we're good at or we love something else so much that we work really hard at it, and other things we just figure out because we need to, or we find someone to help us. But this idea that we're going to be straight A adults is just not something that exists as it does for children.
Right. It's not realistic at all. And I think understanding your strengths and your weaknesses is so critical, which is why I find it very helpful to get that autism diagnosis for many older teens, especially the females who were missed. I think it can give them an understanding, a framework of their strengths and weaknesses. But I think there is the potential flip side of looking at themselves as disabled as a negative thing. And again, that's because you're talking about the disability lens, right?
Right. Yeah. I think sometimes it is nice in terms of getting a better understanding, especially when it comes to social skills, because sometimes people are at high risk for being taken advantage of because they may not realize that they're missing, they might confuse true intimacy with just sort of romance, right? And so that's so complicated for girls and women, even under the best of circumstances. But if you don't intuitively understand social rules or know how to read the room, think of how vulnerable you'd be. So sort of understanding about yourself that you might need to get more information, I think is a really important thing and will help decrease overall your anxiety and depression.
I think so too. And I think also we need to talk a minute about the role of a diagnosis for services,
Hmm.
right? If you're talking about kids, you're a developmental pediatrician, I'm a pediatrician. The specific label can actually lead to very helpful services that you might not be able to get without it.
Right. I think, yes, absolutely, especially for younger children that need more intensive services, then a diagnosis can be helpful. So, um, so I, so it is, complicated, right? Some people want a diagnosis, some don't want a diagnosis, some want a diagnosis to get services when they might not really have that diagnosis. So I'm really, in my practice, I don't give a diagnosis unless I think it fits.
The way I look at it is it's all in the framing.
Mhm.
You can both make a diagnosis for services, which may have to be disability focused because you're focusing on the disabilities to get help for those disabilities, while at the same time, two things can be true at the same time. You're saying, this is what we're doing to get the services, but you have an amazing neurodiverse brain, all brains belong, and you've got all these strengths, maybe not superpowers, but
Mhm.
you have strengths and we're going to focus on them and do those two things at the same time. I think it's in the framing. I don't think you have to walk away from a diagnosis feeling I'm broken because you're not. Autism does not mean broken.
Yeah, it's very nuanced, right? So I think it's
Yes.
just sort of understanding all the nuance and then really explicitly talking about it and not assuming that someone's inferring. And I think having role models is a really important cultural thing. So, people like Jennifer Cook, people like Mel, to your point, exactly what you said, social representations of people are really make a huge impact on public perception and are really
They
important.
do, because we need to understand, right?
Mhm.
And watching someone, a character who you love is really, it's a great way. And I want you to know, she is such a popular character. I don't know if it's my bias because I'm into her and all my Instagram feed, every other thing is something
Mhm.
about Mel. Or, she really is popular. And it's wonderful to see someone who is maybe not diagnosed, but fits the criteria for milder end of autism spectrum disorder, being embraced for
Mhm.
the whole person she is,
Yeah.
right?
Mhm.
So that's a really amazing accomplishment. And I think that you're doing so much amazing, amazing work, both with your physical inclusion projects and your media representation. And I'm really, really excited and honored to have had this conversation. And I want to thank you so, so much for all your time and patience as we work through this.
Well, thank you so much for having me. It was such a great conversation to have. So I sometimes forgot we were even doing a podcast. It was just such a nice conversation. So really, thank you so much for having me.
Thank you. And I think we both can't wait to see what happens with Mel and her sister.
Yeah, yeah, it'll be great.
Wait for season 3, guys.
Yeah, yeah.
Thank you so much.
Thank you.
Thank you for listening to Kids Matter. Raising healthy, happy children takes a village, and I'm grateful you're part of ours. If today's conversation resonated with you, please share this episode with another parent, grandparent, teacher, or anyone who cares about kids. Together, we can build the supportive community our children deserve. I'd love to hear from you. Share your thoughts, questions, or suggestions for future topics at kidsmatterpodcast@gmail.com with no exclamation point. Your voice truly matters. Until next time, keep advocating for the children in your life because kids really do matter. They are our future. I'm Dr. Elisa Minkin, and this has been Kids Matter. Please note that while I am a pediatrician, I am not your child's pediatrician. This podcast is for informational purposes only and does not constitute medical advice. For any medical concerns or decisions, please reach out to your child's healthcare professional.